Why? Why, Peter?
Okay, I'll let you know why. There we go again. This is next generation urodynamics, and I'm going to be fast because this is a lot of knowledge in a few minutes. This is a very, very old standard, and it's a very, very ignored standard that we have in ICS. This standard says, please use this graph that you all know, but also use the pressure flow plot. And I never see anybody using this pressure flow plot, so I need to explain what's the intent of the earlier standard. Here you see the trousseau opening pressure, maximum pressure, pressure at maximum flow, and minimum voiding pressure. And basically that one refers to that one refers to that one, and that one to that one. So here you see pressure and flow, and it is projected like that. So how is avoiding projected in this this pressure flow plot? Here's pressure, here's flow, and pressure goes up in the beginning of the voiding, then flow starts, and this is the pressure flow loop that you expect in voiding. So and the lower pressure loop part of the loop is the passive urethral resistance relation. So keep that in mind. Then you can have differences in pressure flow graphs. So here's the intermediate, and here's the low pressure one, no bladder outlet obstruction, and here's the high pressure one. So the lower pressure border of each of these graphs represent no bladder outflow obstruction, bladder outflow obstruction, and an intermediate outflow obstruction. So that is what is up to now the standard, and this is most valid in men, not invalid in younger men, and maybe applicable for women and children. I have no evidence for the contrary. So, but let's concentrate on men. And here's again the plot, as you see in the average bladder outlet obstruction intermediate. So let's give it, label this type 1. I'm going to add type 2. Sometimes the beginning is normal, but something strange happens. Pressure goes up and not down. So it can go up earlier, or it can go up much more. And those I'm now going to name type 1. Something else can happen. What happens is, so the description is that the curve deviates upwards from the ideal pressure passive urethral resistance relation. And the interpretation is that the outflow resistance increases after Qmax. So pressure up, flow down means increase of outflow obstruction. And the minimum detrusor pressure is not minimum voiding detrusor pressure anymore. So here's another type, type 3. The beginning is okay, like bladder outflow obstruction, but then again something strange happens. Flow continues the same rate, but pressure is lower and lower and lower. And again, in various types, the lowest pressure is much lower than expected on the basis of the normal pressure flow relation graph. So that's type 3. So the curve deviates that the end pressure is much lower. So the passive urethral resistance relation is much steeper than expected, and the interpretation is that the distensibility, the outlet doesn't allow enough Qmax. So this is most typical for men with BPH, three types. So this is the normal volume mass effect. Probably here is the explanation for what happens in the upgoing pressure, and here is the explanation for what happens in the very low end pressure. So our male patients, and here's the clinical epidemiology about these observations. So the patients enter our clinic after failed initial therapy, and they look forward to medical diagnosis, and they ask, can you make something objective? Yes, I can. I can measure what's wrong. I do not need to make a photo. I can measure what's wrong, and pressure flow analysis is the unique opportunity to measure what's wrong. And then I have shown that there's subtypes. So I looked into almost 900 urodynamic tests, and they all voided within limits and good. And then I have those three categories, 3 and type 1. And there's some mathematics behind that. I will save the time. And what did I see? 25% had no bladder outflow obstruction, and the patients referred to me out of these. 24% had intermediate, and 50% had bladder outlet obstruction. And those without bladder outlet obstruction or intermediate, they had the normal curve, almost all had the normal curve, and some were relatively steep. So that's not very interesting. But the patients with bladder outflow obstruction, they had the normal type. Half of them had the normal type, and in the other half, the half of them, so a quarter of all, had that prostate middle lobe kinking, ball valving in type, and the other half had the constricted type. Here's the graph of that. You can expect bladder outflow obstruction in half of your patients, and the funny types in half of that group of bladder outflow obstruction. That's basically the report that I can do. I have some more slides. You are going to ask, what's the clinical relevance? So here we have the discussion. What can we do with this? This is all nice, but what can we do with this? Am I allowed to answer my own question?
Yes, in 1 minute, or maybe less.
I'm 1 minute. I get used to the speed now. So there's my own question.
But then
losing track.
There will be an extra time for that.
Yeah, sorry for that. Yep. So can I manage both types? Which type of manage should I select for those 3 types? Basically, there's more than those 3 types. We have detrusor activity, we have no bladder outflow obstruction, and as you heard an hour ago, you can do everything with prostates. And it's difficult to select, and we cannot do that on the basis of only do that on the basis of prospective analysis. And adding on to this, your urodynamics will give filling phase abnormalities. So the conclusion is that yes, as medical specialists, we make objective assessment of the dysfunction after failure of initial treatment, but these subtypes need prospective studies and prospective analysis. So I think that ICS should update the pressure flow analysis document and prospectively test relevant cohorts with feasible treatments. Thank you.
Thank you, Peter. The paper is open to few questions, possibly. If I don't know if there is one. I mean, I have a lot of questions and curiosity about it. I think it's very, very interesting. And the first comment is that probably we are used to be too much focused on PDAT at Qmax and Qmax. There is much more than this in a pressure flow study. So this is, I think this is the big message coming from this study. The second point is that I would like to ask you a question on that. Usually we don't do a pressure flow study before prescribing a drug. Usually we don't. We usually do before surgery. But for instance, if you see a patient with the third lobe behaving in the type 2 way that you described, what do you think? Should we prescribe a drug, or maybe we should directly go for surgery? I mean, I know
so
that
again, I cannot question. See. I cannot really say. We didn't prospectively evaluate, but of course I can look into my database and I can look into the literature, and especially prostate middle lobes are not sensitive for alpha blocker therapy, so you would advise them earlier surgery, maybe. On the other hand, there are some, let's say, middle lobe or bladder neck sparing treatments evolving now. Mm-hmm. And if you can show that the bladder neck or the prostate middle lobe is the problem, you would not do that. And if a prostate is very constrictive and small, you would not resect the mass, but you would incise the prostate. But again, that is only my speculation, and I can mention a number of studies that could give relevant answers, but we can discuss the rest of the day then.
But referring also to the lecture by Professor Tubaro just a few minutes ago, I think that this is an important message that you are giving, that a whole evaluation of the pressure flow study may help us in the following clinical management if we will be able to prove that it is related to the following outcomes.
Again, the patient is worried, wants to know what's wrong, and if we can measure what's wrong, which is that's why hospitals are built, for objective assessment, and then we can stratify our patients and advise them correctly and ease away their worries. Thank you.
Thank you, Peter.